Note: there is concern that saline-based solutions such as 5% albumin and heparin given in high dosage can induce renal dysfunction. They provide a chloride load that can produce progressive renal vasoconstriction, a decrease in glomerular filtration rate, and a hyperchloremic metabolic acidosis. Furthermore, patients receiving large amounts of normal saline can become hypernatremic, causing intracellular dehydration that may cause central nervous system change and abdominal discomfort. Thus, use of a balanced electrolyte vehicle may provide better acid base and electrolyte balance and better organ perfusion. Notably, heparin may contribute to a metabolic acidosis that might inappropriately raise the specter of poor tissue perfusion, necessitating unnecessary intervention. Hypertonic solutions are effective in augmenting intravascular volume by extracting fluid from the interstitial and intracellular spaces. They may reduce the amount of fluid required to maintain intravascular volume when there is total body fluid overload. 25% albumin can increase the intravascular volume by 450 ml for every 100 ml administered. Hypertonic saline 3% can also be used. Also, it can produce neurologic problems with the development of acute hypernatremia. Studies from Europe have shown that hypertonic saline 7.5% can produce renal vasodilation, increase glomerular filtration rate, and produce a diuresis. It should be noted that use of these hypertonic colloids can produce hyperoncotic renal failure in dehydrated patients because the glomerular filtration of hyperoncotic colloid molecules may cause hyperviscosity and stasis of tubular flow, resulting in tubular obstruction. This effect may also be one of the mechanisms of high molecular weight has induced renal dysfunction. An ideal solution for volume expansion would be a commercially available hemoglobin-based oxygen carrier. Thromboelastographic studies of Oxyvita, a polymerized bovine hemoglobin-based oxygen carrier, have shown similar effects on the coagulation profile as heparin at doses up to 23 ml/kg, but with minimal coagulopathic effects at the recommended dose of 3 to 3 ml/kg. It cannot be overemphasized that the objective of postoperative fluid management is to maintain adequate intravascular volume to ensure satisfactory cardiac output and tissue perfusion. Administration of excessive volume to maintain high filling pressures and the highest possible cardiac output will increase tissue edema, primarily manifest as increased intravascular lung water. This can be detrimental to pulmonary function and will often delay extubation. In addition, the hemodulation caused by intravascular volume expansion may decrease the hematocrit and also reduce the level of clotting factors, possibly precipitating bleeding and necessitating homologous blood or blood product transfusions. When cardiac function is satisfactory, but there is an ongoing volume requirement to maintain filling pressures or blood pressure, often from a combination of the capillary leak, vasodilation, and an excellent urine output, fluiding the patient with volume should be resisted. After 1.5–2 liters of fluid is given, norepinephrine or vasopressin should be used to maintain filling pressures and improve the systemic blood pressure. Norepinephrine is the preferred drug in the vasodilated patient with good cardiac function, since it will improve renal blood flow and actually lessen renal vascular resistance by lowering renal sympathetic tone. Vasopressin 0.01–0.07 units minute is very effective in the vasodilated vasoplegic patient with a good cardiac output in restoring blood pressure to within the renal autoregulatory range, generally more than 80 millimeter mercury. In conditions of low cardiac output, however, it may increase the risk of splanchnic vasoconstriction and bowel ischemia. Phenylephrine should be utilized only when the cardiac output is satisfactory because it provides a pure alpha effect on systemic vascular tone. If both cardiac output and urine output remain marginal after adequate filling pressures have been achieved, inotropic support must be considered first, with use of vasoconstrictor drugs only if systemic resistance remains low. Use of alpha agents at substantial doses is always of concern with a marginal cardiac output because they may produce renal vasoconstriction and compromise renal function. Generally, diuretics are best avoided in the first 6 hours after surgery unless inexplicable oliguria, pulmonary edema, or borderline oxygenation is present. When the patient has achieved a stable core temperature and the capillary leak has ceased, usually after the first 6 to 12 hours, filling pressures will stabilize or rise with little fluid administration. By this time, myocardial function has usually recovered, inotropic support can be gradually withdrawn, and the patient can be extubated. Diuresis should then be initiated to excrete the excess salt and water administered during cardiopulmonary bypass and the early postoperative period. Patients who have undergone operations that require long period of bypass, usually more than 3 hours, or who have persistent low output syndromes may experience a longer period of capillary leak that requires further fluid administration to maintain filling pressures. Diuresis. Diuresis can be augmented most efficiently by the use of loop diuretics. Loop diuretics inhibit sodium reabsorption in the ascending limb of the loop of Henle and increase solute sodium presentation to the distal tubules. By inhibiting tubular water reabsorption, they increase natriuresis and diuresis and prevent tubular obstruction. To a lesser extent, they may also act as renal vasodilators, increasing renal blood flow and glomerular filtration rate, and they may improve medullary oxygenation. Most patients with preserved renal function respond to furosemide Lasix 10 to 20 mg IV. In the absence of renal insufficiency, furosemide has a half-life of 1.52 hours, and thus it can be repeated every 4 hours if necessary. Not infrequently, the diuresis persists after one dose. A gentle continuous diuresis may be obtained in patients with significant fluid overload and hemodynamic instability using a bolus dose of 40 mg followed by a continuous infusion of 0.1 0.5 mg kilogram hour, usually 10 to 20 mg hour of furosemide. This may decrease the total dosage requirements and usually improves the diuretic response, especially in patients who are diuretic tolerant. This benefit is also seen in patients with chronic kidney disease. The addition of a thiazide, chlorothiazide 500 mg IV is beneficial in overcoming this problem of tolerance, which may be caused by compensatory hypertrophy of the distal nephron segments in response to increased exposure to solute from chronic use of loop diuretics. Diuretics are continued in IV or oral form until the patient has achieved his or her preoperative weight, despite the nearly universal use of routine diuretics to achieve an earlier diuresis. One study showed no clinical benefit to this practice in low-risk patients with normal renal function. Low-dose dopamine, 2 to 3 mg/kg minute, increases renal blood flow and glomerular filtration rate, resulting in effective diuresis and natriuresis. This will lower filling pressures, reduce lung congestion, and improve oxygenation. It has been shown to be clinically beneficial with reducing the need for diuretics in postoperative patients with normal renal function.